Hello, my name is Harry Green. I'm a fourth year medical student, and this is my presentation on posterior reversible encephalopathy syndrome, or PRES. PRES is also known as reversible posterior leukoencephalopathy syndrome, although that's what it's known as in literature, but clinically I have only heard the syndrome termed as PRES. So I will continue to refer to it as PRES throughout this presentation. All right, so what is PRES? PRES is a clinical syndrome that often involves headache, decreased level of consciousness, seizures, and imaging involving edema in the posterior cerebral white matter. Although this is not completely consistent, sometimes there can be edema found in other areas of the brain as well. Quickly, causes of PRES: hypertension, specifically rapid changes, rapid increases in blood pressure are kind of one of the main culprits of PRES, but also eclampsia, immunosuppressive agents like chemotherapy, renal dysfunction, autoimmune disorders, and sickle cell disease and sepsis can also cause PRES. For the pathophysiology of PRES, the predominant mechanism that is theorized to cause PRES is an autoregulatory failure of the arterioles in the brain. As blood pressure increases in the brain, the arterioles constrict so that the brain is receiving kind of a steady amount of perfusion. However, it is hypothesized that in PRES, you actually get kind of failure of this system, and you get dilation of the arterioles at very high blood pressures, which can lead to hyperperfusion of the brain and essentially the hydrostatic forces that occur after that hyperperfusion leads to leaky arterioles, and that is how the edema forms, is through those leaky blood vessels. Alternatively, there is another theory that hypoperfusion actually causes this. So it's basically the complete opposite, that as blood pressure increases, that the arterioles vasoconstrict too much and cause local ischemia. This is considered to be a little bit less likely, especially in cases where patients get complete, they after they get PRES, and then after it improves, they have like complete resolution of symptoms. So that makes the hypoperfusion and ischemia hypothesis a little bit less likely. And then endothelial dysfunction is also a potential cause, especially in patients that are taking chemotherapy. It's hypothesized that the chemotherapy can directly damage the arterial endothelium and cause the arterioles to become a little bit more leaky, leading to the formation of that edema. Okay, going quickly through typical imaging findings. Usually you see hypoattenuation in the posterior cerebrum, specifically occipital and parietal regions. On the left, you can see a CT here that has those hypoattenuating areas. And then on the right, I tried to get a CT that's kind of just a similar slice, and that is just a normal CT there. Imaging findings for MRI, T1, there's going to be it's going to be hypointense in the affected areas. You can see on the image, on the lower image, there's some hypoperfusion in those posterior regions. And then T2, that will be hyperintense in the affected areas. Specifically, T2 flare is helpful because with T2 flare, you're canceling out the CSF, so nothing else is going to really show up too bright except for the edema that you can see on that top image. All right, so let's jump into a patient case. A 32-year-old male presents the ED with several days of leg swelling, leg pain, and headache several days after walking over 20 miles for his new job. Previously had been not very active, so a lot of new activity. His past medical history, he has no significant past medical history. His family history is significant for diabetes, hypertension, and notably several relatives with Becker muscular dystrophy. Social history, he frequently uses Zins, and he actually works for Zin, which is a smokeless nicotine company in logistics. No surgical history and no medicines that he's currently taking. As far as physical exam, his blood pressure is 210 over 150, and his heart rate is 102. General, he is well appearing and conversational. He does have 3+ pitting edema up to bilateral hips. And then his neuro exam is basically normal at this point. And then pertinent labs and imaging. His creatinine is elevated and his BNP is elevated. Otherwise, everything else is negative or normal at the moment. So with his blood pressure being over 180 systolic and 110 diastolic and signs of end organ damage with that elevated creatinine, deemed to have hypertensive emergency, and he was admitted to the ICU, and the plan was to lower his blood pressure by no more than 20% in the first hour and then continue slowly lowering it to avoid, rapidly correcting the blood pressure, and which can lead to cerebral, hypoperfusion and ischemia. However, at midnight, we got a message from the nurse. The patient's mental status was deteriorating. He was appearing more and more somnolent and basically not able to identify where he was, who he was, any of that. So we'll go through our imaging findings here. So starting at the top, we'll just kind of go through his scan. And this is a CTA head and neck. And as we go through, we're starting to see here at the bottom, and I'll mark it with my pencil in red. Here at the bottom, we're seeing hypodensities or hypoattenuation on his CT, kind of on both sides in the posterior cerebrum there. We'll take out those two, and we'll continue going down the scan. And as you can see, becomes a little bit more apparent here too. Right in there. I'll switch my color a little bit. And right in here, we're also seeing those hypodensity, that hypoattenuation. And as you go through a little bit more down in here as well. Yeah. So those are the CT findings. And then moving on to the MRI imaging, a little bit harder to see on the T1, but there is hypointensities on this T1 scan, and then on the T2 flare, you can really see the hyperintensities showing that edema. Moving on. So treatment and kind of typical course of PRES. The diastolic, there's pretty tight diastolic goals around 100 to 105, but you do want to avoid reducing the blood pressure by greater than 25% in the first 6 hours. Again, trying to not cause any of that cerebral hypoperfusion, because the brain, and the vascular system in the brain is used to a certain amount of blood flow, so you don't want to decrease that too much. But you do want to tightly control that diastolic blood pressure, typically with easily titratable blood pressure medications, IV blood pressure medications like nicardipine and labetalol. Also, you will want to load these patients with anti-seizure medications, but then also keep an eye, obviously, for him on his renal function. So if you're going to choose something like Keppra, you would just want to dose adjust that for his decreased renal function. And then kind of typical course, the encephalopathy and the confusion often improves over a period of days to weeks. These patients also typically kind of regain full function as with the name, posterior reversible encephalopathy syndrome. And just another pearl, clinical improvement often comes first before imaging improvement, before you see like the resolution of the edema. And lastly, patient outcome. This gentleman, we corrected his blood pressure slowly, and he was able to make a full recovery. It was 4 or 5 days before he was, completely before kind of his confusion lifted. And then he got an echocardiogram, which showed heart failure with reduced ejection fraction, likely secondary to dilated cardiomyopathy. So we think that his initial presentation, his hypertension was probably caused by some baseline hypertension and then also volume overload due to this heart failure. And he was referred to or for genetic evaluation with suspicion for Becker muscular dystrophy causing his heart failure. And it was likely the increased activity that he had with his job that precipitated this event. All right, and here are my references. Thank you guys so much for listening to my presentation.